One thing that we've learned from muscarinic modulators is that the animal model for the positive symptoms of psychosis really does play out in human beings. Sometimes animal research doesn't always translate to humans, but we've generally known from animal models that the positive symptoms of psychosis are related to too much dopamine release in a certain pathway. In the animal model, it was the mesolimbic pathway. In humans, it's a slightly different pathway, but the fact that we have now a muscarinic agonist, which does seem to reduce the positive symptoms of schizophrenia, really confirms something that we always suspected. Well, the big question coming from the three pivotal trials of Xanomeline Trospium is, will we get a cognitive boost from, and what we hypothesize is predominantly the M1 mechanism. It's possible also that M4 may give us some cognitive benefits, but we know that a quarter of patients living with schizophrenia have extremely low expression of their M1 receptors, more than 75% below norm. And what turned out was when they did analyses of cognitive outcomes, they showed that for a subgroup with really low baseline functioning, meaning one standard deviation or even more so, 1.5 standard deviations below norms, they actually did achieve benefit from xanomeline trospium. And it really confirms something again that we may have suspected, that people with low M1 expression may benefit from an M1 agonist. The jury's still out about negative symptoms. Just in the past week, they published the composite data on negative symptom outcomes for the 3 emergent trials. Based upon their analyses, they tried to argue that the improvement in negative symptoms was independent in the improvement of positive or total symptoms. But these are sometimes hard to tease out. When you make schizophrenia better in toto, I mean overall, everything gets better, including negative symptoms. And so to argue that there's an independent negative symptom benefit is something that may require further study. It certainly does make them better. The question is, does it make them more, does it improve them more or disproportionately than you might expect with the degree of overall improvement? And I'm not sure about that. The big issue with muscarinic modulators is that we will no longer have some of the concerns that we previously had with antipsychotics. The big one is the avoidance of risk for movement disorders, especially tardive dyskinesia. These are never things that people ever wanted. These were unfortunately something we had to put up with due to the fact that all antipsychotics prior to this that were approved for schizophrenia were D2 receptor binders. And I feel like people really also put up with prolactin issues and metabolic side effects because this is all we had. The big conundrum, unfortunately, is the fact that currently the only approved muscarinic activating medication is oral. And we know that many people living with schizophrenia have trouble with oral adherence. Anytime you prescribe an oral antipsychotic, even one that's very well tolerated and does not cause weight gain or movement disorders, there's still a risk of non-adherence, which is just the nature of schizophrenia. And clinicians will have to weigh that. There's obvious benefits in terms of tolerability, also in efficacy, but it only works if people take it. And that'll be a bit of a difficult situation to weigh for some people in terms of where to fit this in the algorithm. Should it be prioritized over a long-acting injectable in the first episode patient? I'm not sure. I would like to offer it to them. On the other hand, if they don't take it and they relapse, every time somebody relapses, they lose drug responsiveness, and you may lose something that you don't gain back. And that's a difficult situation to weigh. Well, clinicians are the prescribers, and it's incumbent upon them to understand how to use the medication. Xanomeline trospium comes with a number of unusual warnings, which relate to peripheral anticholinergic burden, concerns about urinary retention, especially in older males, obviously constipation as well. Clinicians will have to know about those, know how to use that. Also, clinicians have to come to appreciate the fact that because it's a muscarinic agonist, They really want to make sure people are not on other centrally acting muscarinic antagonists like benztropine or diphenhydramine, because those, based upon the animal research, may interfere with xanomeline's mechanism of action. I think the last thing clinicians will learn is how to titrate it. There was a fixed standard titration that was done in the clinical trials, and we saw certain rates of nausea and vomiting. Those rates of vomiting may be unacceptable to a lot of patients and clinicians may learn how to adjust the titration to minimize that particular adverse effect, which is seen really just early in the course of therapy. Well, it's really opened the possibility that we can treat symptoms of schizophrenia and not incur a lot of the D2 related adverse effects that we've always been fearful of, especially prolactin related problems and movement disorders or tardive dyskinesia. This is exciting. That we may also get some cognitive benefit is even a double bonus, but I think most people have been very happy just with the fact that we have a drug which doesn't do a lot of the things that we got from D2 binding antipsychotics. And I think for the future of schizophrenia, we now have come away from the need to have to use the D2 receptor as part of the mechanism to a whole other way to modulate the symptoms of schizophrenia, especially the positive symptoms with a muscarinic activating agent. Well, Xanomeline has three pivotal studies, and when you look at the overall effect size across the three studies, it's 0.65. This is as high as we've had since the approval of olanzapine on September 30th, 1996. People are looking for efficacy and also secondarily they look for tolerability. But here we have a drug which may be more effective than existing agents. Not necessarily going to be effective for resistant schizophrenia or the same as clozapine, but it certainly might be as effective as the most effective oral agents we have out there, such as olanzapine. And most importantly, it doesn't have any of the baggage associated with some of those agents. A lot of switches, I think, will be for efficacy. There will be some for tolerability. The last question, which I addressed earlier, is would it be the first drug you give somebody living with schizophrenia? I think you can make a compelling argument if you have some sense that this person might be orally adherent.